yourself, please. Okay, I think it is time to start. Dr. Rajiv, sir.
I'm there.
Sir, I would request you to start. I will call up Ajay Khanna, sir, because it's 8 o'clock.
Right.
Sitting, sir, I will call the remind the others.
Good evening, Dr. Rajiv sir. Dr. Amit Gupta
Good
here.
evening. Good evening, sir. Good evening, sir.
Good evening, sir. Sir, Rajiv Sahai, sir, is from Hindura Hospital, New Delhi, sir.
Yes, sir.
So, Dr. Manish, good evening
Yes,
to
sir.
you. Can you try sharing your PPT? Please introduce your unit chief, head of the department, and start your presentation. Sir Khanna, sir, good evening, sir. Sir, are you able to hear us, sir? Good evening, sir.
Yes, I'm able to hear. Yeah,
Yes, sir. Thank you, sir.
Yeah.
Thank you, sir. Thanks for
Good evening,
joining.
Dr. Ajay Khanna, sir.
Good evening. Good evening. How are you, Dr. Amit?
Fine, sir.
Sir, Dr. Sachin Jama and others are going to take some time to join, sir. So we will start now. So let them join a little later, sir. Dr. Manish, you please start your presentation. Good luck to you.
Thank you, sir. Good evening, everyone. I'm Dr. Manish Kulshresht, third year PG in the Department of General Surgery in AIIMS Rishikesh. My moderator is Professor Amit Gupta, in Department of General Surgery, SPB unit. So today's case is a...
Dr. Manish, one moment. Jaswant, sir, good evening, sir. Professor Jaswant is the Director, Institute of Surgical Gastroenterology and Liver Transplantation in Government Stanley Medical College. Good evening, Dr. Jaswant, sir. I think he's yet to join.
Hello.
Good evening, sir. You please continue, Dr. Manish. Sir,
So today's case presentation, we are presenting a case, Mrs. X, 60-year-old lady, a resident of Roorkee, Uttarakhand. She's a homemaker. She presented with the chief complaints of yellowish discoloration of eyes for the past 3 months, yellowish discoloration of urine for the past 3 months, loss of weight and appetite for the same time, itching over the chest and trunk for the past 2 months, and passage of black tarry stools for the past, and a history of passage of black tarry stool 2 months back. Going to the history of present illness, we can see that the patient had yellow discoloration of eyes, which was for the past 3 months, noticed by her family members. There was a waxing and waning pattern noticed. Yellow discoloration of urine was also for the past associated with the symptom. Patient also had a passage of clay-colored stools, and there was a history of black tarry stools 2 months back, which was associated with clearing of urine color for 5 days. Following which, again, she developed jaundice, yellowish discoloration. Itching over the trunk and chest was, according to history, she said for the past 2 months. And there was a history of loss of appetite and unintentional weight loss, which was elicited by loosening of clothes for a rough period of past 3 months. There was no history of any pain abdomen or vomiting, no history of any fever, malaise, generalized weakness, joint pain, no history of any abdominal distension, no history of altered bowel habits, no history of any decrease in urine output or altered sensorium, no history of hemoptysis, seizures, or backaches. Going into the past medical and surgical history of the patient, there were no comorbidities. There was no history of TB, hypertension, any new onset type 2 diabetes, asthma, or any signs or no history of any hyper or hypothyroidism. There was no previous history of jaundice or pain abdomen before this episode. There was no history of any blood transfusion or IV drug abuse or tattooing in the past. There was no history of previous hospitalization. There was no history of any chronic drug intake, and she has not undergone any surgery in the past, and there's no history of any allergy known to her. Going to the personal history of the patient, she takes mixed diet. There's no history of any addiction. Her sleep is occasionally disturbed due to itching. She's married with 3 children, P3, L3, all normal vaginal delivery at home. She attained menopause 20 years back. Going into the family history, we can see that the patient had no similar disease in the family. There was no history of any malignancy or malignancy-related deaths in her family. I would take this opportunity to summarize the history once. A 60-year-old postmenopausal lady presented with painless waxing and waning jaundice for the past 3 months with itching over the trunk and chest, passage of clay-colored stools, and 1 episode of black tarry stools 2 months back with yellowish discoloration of urine and loss of appetite and weight with no prodromal symptoms. Should I go ahead with the...
No. Dr. Kush. Dr. What's the name? Kulshresh.
Dr. Manish. Yes, sir.
Manish. So what do you think you're dealing with?
Looking at the history, I think the patient is having obstructive jaundice, and which is most probably secondary to some malignancy.
So why do you call it it's actually called surgical obstructive jaundice?
Surgical obstructive jaundice.
Why
Yes.
do you call it surgical obstructive jaundice?
Obstructive jaundice because it is mostly because of the obstruction of the biliary tract, and so it is called surgical because most of the diseases are treated by any surgical intervention or nowadays endoscopic interventions.
Okay, so why in your history, just why do you think the patient has obstructive jaundice?
Just by history, if I have to go, the patient is having yellow discoloration of eyes and urine at the same time, associated with passage of clay-colored stools, sir. And it is also associated with itching or pruritus.
Dr. Manish, pruritus is a very peculiar feature of obstructive jaundice and should be said much earlier than pale stool. Pale stools are not very common.
Yes.
It's not very common. Okay.
Yes.
So let's go back to your first slide now. 60, the next slide. Suppose that the urine was not yellowish discolored and the patient still had jaundice. What would you think of?
I would think of acholuric jaundice, which is mostly...
Why does that happen? Can you explain the pathophysiology of that?
It is because it is usually seen in cases of hemolysis and due to unconjugated bilirubinemia. Usually, yellowish discoloration of urine comes because of the conjugated bilirubin, which is water soluble, and it being filtered through the kidneys.
Okay, so can you tell me that? Okay, Dr. Mesh, what is the name of the test which you do for bilirubin direct and indirect? What is the name of the test? You must have studied in your physiology.
Yes, I just currently can't certainly recall.
It's Vandenberg test.
Yes, Vandenberg test. Yes, sir.
Okay. Passage of black tarry stools 2 months back. Why did you think he had that?
It is in this case in a backdrop of just black tarry stool itself is a significant, it's suggestive of a upper GI bleed, and as it above the ligament of Treats. In this
Okay. Okay, fine.
in this scenario, in which the patient is a case of obstructive jaundice, there can be it can be due to a ampullary growth, ampullary tumor, which outgrows its vascularity and sloughs off, leading to bleeding and manifesting as a symptom of black
Any other
tarry stool.
reason? Any other reason for? Okay, one could be you say that is ampullary form of malignancy. Any other reason?
Papillary type of distal cholangiocarcinoma also has the similar pattern.
Papillary type is?
Papillary type of distal
I
cholangiocarcinoma.
mean, it is ampullary type. You can't just make.
Okay, ampullary types.
Any other reason?
Patient can have a duodenal carcinoma, adenocarcinoma,
Okay. So duodenal
in
carcinoma.
the
Any other reason?
2 centimeter.
Okay. Any other reason?
The patient can have secondary biliary cirrhosis, which can lead to
No, don't take it that much. What about carcinoma head of pancreas? Can it cause melena or hematochezia?
If it involves the duodenum,
Right.
and
So it infiltrates into the duodenum, but it can still.
It can cause melena.
Okay, next slide, please. Okay, next slide. You said no history of vomiting. So which kind of periampullary carcinoma you'd find vomiting commonly associated?
If there's a growth, periampullary carcinoma that has infiltrated the duodenum and is causing gastric outlet obstruction, in those cases we can see.
What about pain?
Pain can be a pain is usually painful. Jaundice would point towards usually CBD stones or gallstones, and also if there is a associated pancreatitis.
And what about the CA pancreas? Can it cause pain?
If it leads to pancreatitis,
and
also it can, if it involves the retroperitoneum and is advanced in those cases.
Right. It's an advanced stage of periampullary carcinoma, CA pancreas. So please. Okay, next slide. Next slide. Let's go. What about joint pain? Why do you ask for joint pain?
I had taken this battery of negative history to rule out any prodromal features which would rule out medical jaundice due to hepatitis.
Okay. Next slide, please. Okay, next slide. Sleep is disturbed due to generalized itching. Right. So what did she do for if she had itching? Did she take any medication for it?
No, she was not on any medication. Usually she gave history of going to some local priests for the procedure, for the itching, she thought, because it was...
Okay. So why do these patients have itching?
It is due to deposition of... although the pathophysiology is not completely understood, but mostly due to deposition of bile salts in the skin, and also due to increase in the circulating histamines, and there can be increase opioid receptors in the circulation.
What was that? Increased opioid receptors?
There's a central mechanism in which mostly I'm not very sure of the complete pathophysiology, but I had just read about it, the third point.
Okay. You said there's no fever. Suppose this patient had fever. What could be the causes of fever in this patient?
The first differential I would think of is that the patient has gone into cholangitis.
Very good. Okay, next slide, please. Similar disease in the family. Which disease are you looking for?
I'm looking for a similar kind of a picture, obstructive jaundice picture in the family, because many a times malignancy might be missed or not diagnosed before the death of the family members.
No. How does it help you in making a diagnosis here?
Usually malignancies, there are genetic predispositions, so we want to rule out that if there is any
Okay,
genetic.
which malignancies are genetic here in which cause obstructive jaundice?
Uh, uh,
Can CA pancreas be associated with other malignancies which run in the
yes,
family?
Men's syndrome and usually run families, and
Men's syndrome or BRCA?
BRCA is also
BRCA.
there.
Right, BRCA is the one. Okay, next slide, please. Right, sir. Should we move to the examination, sir?
Manish, what do you understand by waxing and waning jaundice?
Waxing and waning jaundice is when is when the jaundice is decreasing but not completely vanishing, and again it's after a period of clearing of urine and clearing of discoloration, it comes back again.
And what is intermittent jaundice?
Intermittent is when there are uh, uh, episodes of obstructive jaundice with disease-free interval in the middle.
So what is the difference between these two, waxing, waning, and the intermittent?
Intermittent jaundice are usually seen in waxing waning is typical of ampullary carcinoma, and waxing waning as intermittent jaundice is very typical of choledocholithiasis.
So in one case, the bilirubin will almost disappear.
Disappear, yes.
Okay. While in other, it will persist. When
Yes.
it will go down, but it will persist.
Yes.
So what are the causes of waxing waning jaundice?
There can be biliary parasites. There can be choledochal cysts. There can be hemobilia. Choledocholithiasis can also be there, and
in your case, you will not think of all these things here, but you are thinking in terms of the malignancy here.
yes.
So malignancies can cause the waxing waning jaundice.
As previously said, duodenal carcinoma can be there, which is within 2 centimeters of the ampulla.
The one is the periampullary carcinoma. Any other carcinoma which can lead to the waxing waning jaundice?
Klatskin can also show a similar picture.
It's Klatskin tumor. It is not a periampullary carcinoma, but it is a higher up. In the Klatskin tumor can cause the waxing waning jaundice.
Yes.
Right. Why there is a clay-colored stool in the case of the jaundice patient?
The color in the stool is because of stercobilinogen, which is produced in the large gut by degradation of bilirubin, conjugated bilirubin. Since in obstructive jaundice, the bile is not entering into the biliary tract in the enteric system, therefore the color is lost and it leads to clay color of stools.
Do you think the color of the urine is because of the urobilinogen?
No, urobilinogen does not have the color. It is because of conjugated bilirubin leaking into the circulation because of accumulation into the biliary tract, and that is excreted through the urine and gives the color.
Did you ask about history of night blindness in your patient?
I should have asked because of vitamin A deficiency.
In how much percentage of cases of the obstructive jaundice you can have the night blindness?
I'm not sure.
In about 10% of the pancreatic tumors, you can have the night blindness because of the vitamin A deficiency in these patients. So you should, apart from asking all those things which are there, you should also ask about the night blindness. Okay, I think you can go on the examination now. If anybody else want to ask, go on the examination. Yeah.
We start the examination by doing a general survey of the patient. The patient seemed alert, conscious, cooperative, oriented to time, place, and person. She had a normal build and nutrition, was well hydrated, which was elicited by the moist tongue. She had icteric faces, which were the yellowish discoloration of the eyes and skin. She was having decubitus of choice. Her weight was 45 kgs, height 157 centimeters, so that gives a BMI of 18.25 kgs per meter square. Her ECOG scale was 1, and Karnofsky scale, performance scale was 80. There was no gait abnormality and no obvious deformity. The icterus was present. No pallor was present when examined over nail beds and dorsum of tongue. There was no clubbing, cyanosis, pitting edema, generalized lymphadenopathy. Left supraclavicular fossa was also examined, and lymph node was not palpable. Neck veins were not visible, and no lump was palpable in the neck. Scratch marks were present over the trunk, and there were no signs of chronic liver disease like koilonychia or pale leukonychia, tremors, spider nevi, loss of axillary and pubic hair. Going ahead, we saw that the patient was afebrile to touch, and on taking temperature in the axilla, it was 98.6 degree Fahrenheit. Her pulse rate was 76 beats per minute, measured in the right radial artery, regular in rhythm with good volume, with no radioradial or radiofemoral delay. Her blood pressure was 110 by 70 millimeter of Hg in supine position, taken in the right brachial artery. Respiratory rate was 18 cycles per minute, which was abdominal thoracic in type, and her saturation was 98% on room air. Going to the per abdomen examination, on inspection, her abdomen looked distended. All quadrants were moving proportionately with respiration. Bilateral flanks appeared normal. Umbilicus was inverted and was in the midline. Scratch marks were present. There were no dilated veins, sinus or fistula, or scar marks. There were no visible peristalsis or pulsations. Hernial orifices were examined and no visible cuff impulse was present. Inspection of the back and spine was unremarkable. External genitalia also appeared normal. Going into the palpation of the abdomen, on superficial palpation, no local rise in temperature or tenderness was present. A well-defined globular lump of 7 to 5 centimeter was palpable below the right costal margin, near the tip of the 9th intercostal cartilage, with a smooth surface, soft consistency, moving with respiration. Upper margin was passing deep to the right costal margin. No other lump was palpable in the abdomen, and there was no tenderness on deep palpation. Liver and spleen were examined and they were not palpable. Hernial orifices were intact. No cuff impulse was present. No fluid thrill was present. No spinal deformity or paraspinal tenderness was present. No renal angle tenderness was there or fullness was seen. On percussion, the liver span was percussed and in the midclavicular line, and a liver span of 12 centimeters was documented. Percussion over the lump was dull and continuous with the liver dullness. There was no shifting dullness, and bilateral angles were resonant. Renal angles were resonant. On auscultations, bowel sounds were present. Left supraclavicular lymph node was absent. On rectal examination, perianal skin was normal, no fissure, fistula, or induration or tenderness was present. Then we proceeded with DRE, and there was no mass. Mucosa was freely mobile, no free fluid or deposits in the pouch of Douglas. Finger fecal stain was present, which was clay-colored stools could be appreciated. No blood stain was present on the finger. PV examination was unremarkable. Other systemic examination was done and they were all unremarkable. No breast lump or thyroid was palpable. Summarizing the history and examination findings, a 60-year-old postmenopausal lady presented with painless vaccine-waning jaundice for the past 3 months, which itching over the trunk and chest, passage of clay-colored stools, and 1 episode of black tarry stool 2 months back, with yellowish discoloration of urine and loss of appetite and weight. On examination, she was icteric and gallbladder was palpable.
Okay. Right. Manish, could you go back to your examination? Right. Okay, next slide. No signs of chronic liver, no lymph. Bilateral pitting edema. Where? Pitting edema where?
Ankle, we measured in the ankle, checked it in the ankle because the patient was ambulatory.
Suppose there was non-pitting edema, then what does that tell you?
That tells me that the patient has lymphedema.
Lymphedema or what? Why? What's the difference between pitting edema and non-pitting edema?
Mm. Pitting edema would be if I put pressure over the bony prominence, mostly 2.5 centimeters over the median malleolus for 3 to 5 seconds and then release it. I would see that there will be a depression and that would slowly come back. In non-pitting edema, I would see that pitting is not possible and the whole there will also be signs of pitting
So why
won't be
is pitting possible in chronic lymphadenopathies? Lymphangitis. Why is it not possible? Because there is inflammation, right? There's compartmentalization.
Yes, in cases of cellulitis or in lymphatic.
Stemmer sign? What is stemmer sign?
Sorry, I could not follow, sir.
Stemmers, S-T-E-M-E-R-S.
Stemmer sign. I think I'm not aware.
Yeah, we're able to pinch the skin over the dorsum of the foot.
Okay.
So you can't do that in non-pitting edema.
Non-pitting edema.
Next slide, please. Okay, next slide. No, why do you take off radio? Just go back. Radiofemoral delay. Why? Do you do that on all cases? What's the
since it's a case presentation, so I followed the.
No. You tell me the reflexes also case presentation. Any importance in your case?
It was not relevant, sir. I should not have kept it.
Just do it with it.
Yes.
Right. Next case. Next slide. Dilated with sinus of fistula. Which sinus of fistula are you looking out for in an abdomen?
If there were usually
in this case,
previous.
Why do you think a case of obstructive jaundice would have sinus of fistula?
Again, I think it's irrelevant then.
Yeah, yes. Present a case like a surgeon, right?
Yes, sir.
Okay. Next slide. Fluid thrill. When do you get fluid thrill, and when do you get fluid thrill?
When there is a free fluid in the abdomen, which is more than 500 ml.
So when will you get shifting dullness?
When it is more than 1 liter. I think.
Is it that way or the other way? Fluid thrill when it's absolutely distended.
It is other way. Yes, sir.
There's no other, right?
So, yes, sir. The other way.
You've not done shifting dullness and you're going in for fluid. When you say the abdomen is the shape of the abdomen. Just go back. Shape of abdomen. We're given the shape of abdomen.
Looks distended. That's what I mentioned.
You have not mentioned it. So, right. Next slide. Would you expect fluid in this case?
If the patient has malignant ascites, I would, and also if the patient has a secondary biliary cirrhosis, that can also lead to free fluid in the abdomen.
Right. Okay. Next slide. Okay. Another thing. Local rise of temperature. Why? Local rise.
To look for
Local where? Superficial palpation. No local rise of temperature or tenderness. Where? Where in the abdomen?
over the 4 quadrants, I would check.
So your patient is afebrile, and then you still go over all of the abdomen looking for temperature. You want.
No.
Okay, next slide. Okay, next slide. Now you've given no shifting dullness here. You did
Yes, percussion.
fluid fill in what? How did you do fluid fill in palpation?
I had put fluid thrill in palpation.
Okay, next slide. You've done per vaginal examinations, did you? Why?
For completion's sake, sir.
Oh, you're not
And
allowed to.
also, if there is any, although a DRE would be sufficient to check for any Blummer shelf, PV
Did
examination.
you check for a tonsils? Did you check for a tonsils? No, you didn't.
No.
Why PV?
Yes. I should not have kept that.
Okay. So please.
Manish, what is the difference between the scratch mark of a skin condition and scratch mark of a obstructive jaundice?
I'm not aware, sir.
If the skin infection is there, there can be the itching may be there.
Erythema and other signs of inflammation can be there. Exfoliation can be there if there are other skin conditions.
Scratch marks in the jaundice patient will bleed because of the coagulation problem. While if it is just a skin condition is there, it will not bleed. So if you find the scratch marks along with the bleeding there, it is more likely to be because of the jaundice patient. Now, if you have to see for the veins in the abdomen, where you will see for the veins?
I would start looking at the periumbilical region first, and to elicit it even more, I can ask the patient to sit up and cough also. And following which, I would like to milk the veins and check the direction of the flow above the umbilicus and below the umbilicus.
So where you should do it? Above the umbilicus or below the umbilicus? If you want to check the flow of the blood. Why do you want to check the flow of the blood? The reason for that?
To see that, to make a differential that why is it that, whether it is due to a superior vena cava obstruction or an inferior vena cava obstruction, or is it due to CLD portal hypertension?
So how will you differentiate between the IVC and the portal obstruction? Where
There
you
is
will examine for the veins? Above the umbilicus or below the umbilicus?
above the umbilicus. Will rule out both IVC and portal vein, because in case of portal hypertension, the veins will be filling up from below upwards, and in case of IVC obstruction, the veins will be filling up from upward, from top to bottom.
No, you should always examine below the umbilicus. Because only below the umbilicus, the direction of the flow will change. Okay. In the case of the IVC obstruction.
Yes, sir.
From
Below
below
the
up?
umbilicus. Yes.
Yes. And in the case of portal obstruction, it will be up down. So you should always examine. If you have to see you must
Below
make
the
the patient
umbilicus.
standing and then examine for this. Not in the lying down posture. In the
Lying down
standing posture, you should carry out. What are the other ways to differentiate between the veins of the IVC and the veins of the portal obstruction? Apart from the flow?
We can also see the direction. If it is periumbilical, mostly it is due to portal vein,
Mhm.
and if it is more laterally present, then it is mostly due to IVC or superior vena cava, either. But
Look
in
at
this
the
case,
back of the
mostly it is.
patient, okay? Look at the back of the patient. If you find the veins, prominent veins there, it is more likely to the
IVC.
IVC obstruction. है ना? So these are the two ways, the direction of the flow below the umbilicus, not above, below the umbilicus, and looking at the back of the patient. Third is the edema. If there's a bilateral edema is there, pedal edema is there, it is more likely to be a case of IVC obstruction. In the case of portal obstruction, it may be because of hypoalbuminemia.
Yes.
But because of the IVC obstruction, you can get the bilateral pedal edema. Okay, so these are the ways to differentiate between the IVC and the portal.
Portal.
Now, what external genitalia you have examined in your female patient?
I wanted to look for any vulvar edema if it's present because of hypoalbuminemia.
But your patient is not having any edema as such, you said, Jay. Then why you want to see the vulvar edema there? Usually in the female patient, it is not advisable or it is not good to say the external genitalia.
Yes.
Okay. So that word usually should be avoided, Jay, in a female patient.
Yes.
Why did you examine the breast and the thyroid in your patient?
Because there are so many cases where dual malignancies can be present. So we wanted to rule out if there is any breast lump, which usually goes unnoticed.
How many cases you have seen during your 3-year residency with the patient having a periumpary carcinoma and also the breast lump is there?
We had seen one case which was reported, and since then we have usually tried to rule out. And since the patient is also above 60, physical examination of the breast was done.
It is good to you examine the breast examination as a screening procedure, but otherwise in your patient probably it is not required.
Yes.
It is very, very extremely rare. You can get it, but extremely rare. What is icteric facies? I heard this name for the first time. I don't know. What is the icteric facies?
Usually the term is actually hepatic facies is usually present, in which there is hollowing of the temples of the patient with malar prominences, pinched up nose, yellowish eyes.
Is that
Which is,
called as icteric? I don't know. I really do not know that. Is that called as icteric facies? Not I. Dr. Sahai can tell if it is there or not. I'm not sure about that.
No, never heard of that.
You're
You're right, sir.
Now, in your case, you have said that the lever span is 12 centimeter.
Yes.
And your gallbladder lump is 7 centimeters.
Yes.
In the same area, in the mid-clavicular line. How do you justify that? Can you justify that? You understand my question?
Yes, sir.
You said the lever span in the mid-clavicular line is 12 centimeters.
Yes, sir.
And in the same area, there's a gallbladder lump of 7 centimeters.
Yes, sir.
Both these lumps there will be continuous lever dull, will be continuous note will be there, the same note will be there, dull note will be there.
Yes, sir.
So this will be not a correct statement.
Okay.
So if you want
Actually,
to modify that statement, what you are going to do? You will not say the lever span in the mid-clavicular line now. You will say it in the
mid-axillary line.
you go on the anti-axillary line there.
Anti-axillary.
Right. So do not say on the mid-clavicular line, but in the anti-axillary line, the lever span is this much. So tell what are the various differences between and how much is the difference in the span in the anti-axillary line, mid-clavicular line, and in the epigastrium.
In the mid-axillary line, it is usually 9 to 12.
Mid-axillary line. No.
Mid-clavicular line.
Mid-clavicular line, yes.
I'm not aware of the mid-axillary and epigastrium.
Yeah, 2 centimeter on every one. Okay. So if you say it is a 9 to 11 centimeter in the mid-clavicular line, it is 13 to 15 centimeter in the anti-axillary line and another 2 centimeter in the mid-axillary line. And on the epigastrium, it is around 7 to 9 centimeters. Okay. I think that's it here. So go to your diagnosis now.
Provisional diagnosis is obstructive jaundice secondary to periampullary carcinoma. In my DDs, I would like to keep distal cholangiocarcinoma, duodenal adenocarcinoma, carcinoma head of pancreas, followed by carcinoma head of neck, carcinoma gallbladder of neck.
What is periampullary carcinoma?
Periampullary carcinoma is uh, any carcinoma which is originating 2 centimeter in a diameter of 2 centimeters from the ampulla.
So what are the various periampullary carcinomas?
There can be ampullary carcinoma, there can be distal cholangiocarcinoma, carcinoma, adenocarcinoma of the duodenum, which is lying close to the 2 centimeter diameter of the ampulla, and carcinoma head of pancreas
Within 2 centimeters
within 2 centimeters.
of the ampulla. Hai na? Right.
Okay. Good evening. Can I ask a question? Dr. Kanagavel is still speaking. This
Yeah,
is Dr.
please.
Shilpa Rao.
Dr. Shilpa, please go
Yeah.
on.
No. So I was listening to it and I just wanted him. So, he said this is a continuously progressive obstructive jaundice. So just for the sake of completion, could he tell us the different types and the causes of the different kinds of jaundice, surgical jaundice?
Yes, ma'am. We have progressive jaundice, progressive
Yeah.
obstructive jaundice,
Yes.
intermittent obstructive jaundice,
Yeah.
and we have waxing and waning type of jaundice, which does not completely
That is
clear.
the same as intermittent, right? So
Intermittent.
intermittent has 2 varieties?
Yes, sir. Yes, ma'am.
Yeah.
One is which completely clears and one that does not completely clear.
Okay. And
there can be obstructive jaundice can be present, which is partial obstruction can be there.
yes. So
Partial
can you give us a couple of causes of each of those? I mean, you mentioned the progressive pretty exhaustively. Can we have a couple of examples of the rest? Like chronic intermittent waning and waxing. That is
yes,
because of?
because of choledocholithiasis, or it can be due
Okay.
to choledochal cysts,
Okay.
or it can be due to parasites in the biliary tract.
Which parasites?
Clonorchis can be there,
No,
sinensis,
in India,
or
which is more common here, yeah.
ascaris can be there,
Yeah.
and
Okay.
it can be due to trauma following hemophilia,
Okay.
which also shows a similar pattern,
Yeah,
and it
nice.
can be due to a duodenal diverticula,
Okay.
which
All
is
right,
a
you
very
well
rare,
read. All
very
right. And
rare.
what are the causes of segmental jaundice? I mean, segmental blockages.
Segmental blockages are mostly seen in trauma patients
Only.
due to trauma, and
So any inflammation in a specific
inflammation.
area, which can also affect only one part of the ductal system. So
Yes,
chronic pancreatitis can affect both. It can affect only one side. It can happen. So any inflammation in that area can also cause this, right?
segmental, yes.
Segmental.
That's the fourth type of.
Yeah.
And
Yeah.
in partial, we have strictures can be there, benign strictures, which are most commonly seen.
Yeah. And benign strictures.
Benign strictures and
Any post-surgical?
yes, if there's a bile duct injury. In those
No,
cases
no.
also.
Then that though will cause progressive jaundice, right?
There's, partial injury causing stricture.
Okay.
Yes, stricture of after HJ, if there is a stricturing
Yeah.
of the
So if the HA is not
divisions,
adequately wide,
adequately wide.
yeah, and this thing, then that can also cause chronic intermittent kind of jaundice. Yeah, good, nice. Please continue.
So
Yeah,
Manish,
Mani,
sorry.
just one thing I will like to add, that you were asked a question about the causes of ascites. So you mentioned that it can be because of the malignancy, or it can be because of the biliary cirrhosis if patient is having a long-standing jaundice. So one more thing which can be often seen in such patients is nutritional ascites, right?
Nutritional ascites.
Yes, correct.
Dr. Manish, you've given a differential 1, 2, 3, 4. Of these, which is the most common? Can you put them in order of commonality? Which is more common? Which is the most common type of periampullary carcinoma?
Usually, carcinoma head of pancreas would be
Then?
there, followed by distal cholangio and ampullary tape.
No. Okay, followed by ampullary. What? Ampullary. Then?
Then followed by distal cholangio and duodenal carcinoma.
And last. What
Last.
CHGB of CA gallbladder? Is it common? Commoner than most of these or not?
Commoner than most of these, because in the endogangetic belt we have a
Right, it's
higher.
the most common. So CA carcinoma gallbladder should be much higher. Now, why do you think this patient, you felt the gallbladder, right? Why do you think the gallbladder is palpable here?
The gallbladder was palpable because of distal obstruction of the CBD, as per the Courvoisier's law. In this scenario, it was because of the ampullary growth, which was causing the obstruction. If I would go for distal
So if
cholangio
there's
again,
an ampullary growth, will the patient have any form, any feature of pancreatitis?
there can be episodes of pancreatitis, but in this patient, we did not have any symptom as such, or it might have gone unnoticed.
What symptoms would be particularly seen in this patient if they had pancreatitis?
Pain in the epigastric region, which is radiating to the back and relieved on stooping forward, which would last. It would be episodic in nature, and might be associated vomiting associated with it.
Okay. So I say that this patient has got carcinoma gallbladder, because they've got a palpable gallbladder, right?
Yes.
Tell me why is it right or wrong?
Just because of the history of melena, I had kept the other two differentials in the.
Melena is, you've not been able to demonstrate melena.
No, sir.
There was a single episode.
Yes.
Right. I mean, this is it could be just episodic.
Yes.
Right? So you can't give too much weightage to that and put it as ampullary carcinoma. Right. So what about how will you differentiate this lump of gallbladder from a carcinoma, or from a benign from a malignant lump of gallbladder?
Usually if the fundus of the body is involved, the consistency will be hard, and
do you think this was involved? There was a tumor in the fundus of the body, or you think it was distended?
It was the neck. I
Why
mean, if I
are you so specific about the neck? Why are you so specific about the neck?
Because the gallbladder which was palpable was soft, and also there was obstructive jaundice associated with it.
So that could be because of CA ampullary carcinoma. You get a distended gallbladder. You didn't say this is a distended gallbladder. You said, just go back to your slide. What did you describe it as? Is it a mass
distended gallbladder? I have described it as a distended gallbladder.
So why keeping it as carcinoma gallbladder off neck? Right.
Dr. Sahi, can I make ask him a
Yes, please.
question about the melena also? Manish, right?
Yes.
What is it likely to get melena generically in a patient of OJ, not because of the site of the malignancy?
Um,
What happens to the
Understood.
pathophysiology in OJ that can cause, in fact, torrential bleeding can happen.
Yes.
We've
If there
asked
is
this question.
associated,
Yeah.
if there is associated biliary cirrhosis or a
No,
patient is
no. We are going too far-fetched. What happens in OJ? What is one of the first tests that you want to do in addition to all your standardized tests? Because patient can sometimes just present with bleeding all over the place. So why?
Why do you give vitamin
because of
K?
yes, because of coagulopathy.
Yeah. So you can get it in any patient of
Any
OJ.
patient.
Yeah.
Yes.
So by itself is not a diagnostic factor. One, I mean, you would start thinking of it, but it can happen in any patient of OJ,
Any
no
patient.
matter what the cause. Right?
Yes, yes, ma'am.
Yeah. Yes, Dr. Sahi, please take over.
Okay. So Manish, how do you go about it? You've got this patient in the OPD, this lady, and this is your
Yes.
patient. Well, how do you go about it? What do you do with the patient? She's
Yeah,
sitting in
just
front of you in the OPD.
one interruption.
Yeah,
Manish,
please.
actually, Dr. Sai asked you a question that why you are not considering the diagnosis of a carcinoma gallbladder as a first diagnosis in this lady, because your answer should be that what is the most predominant symptom in patients of gallbladder carcinoma? That is pain in abdomen, right? So this patient never had pain abdomen, right? So on clinical grounds, you will never give gallbladder carcinoma as first diagnosis in this lady, right? So that should be your answer.
Right, sir. In fact, only two of these malignancies, CA gallbladder and CA head of pancreas, they present with pain.
Yeah.
Right. So this lady is sitting in your OPD on the stool. Now, what do you do with her, Manish?
Manish, what are the causes of jaundice in a patient with CA gallbladder?
Causes of jaundice in a case of CA gallbladder would be either direct infiltration into the CBD or due to a portal lymphadenopathy, or due to any metastasis in the liver which is causing biliary obstruction, specifically in the caudate lobe, or it can be due to, or specific, or the size of the metastasis is large enough to cause obstruction in the biliary tree, or if there is any associated choledocholithiasis in the patient. And
What is the chance of having a choledocholithiasis in a patient with CA gallbladder?
it can be around 10 to 20%.
Around 10%, yeah. And what is the chance of having the cholelithiasis in the patient with the CA gallbladder?
Previously, reports have shown around 80 to 90%, but in recent studies coming from India, we are having 65 to 75 also percent. But no correlation has been seen as such with choledocholithiasis and carcinoma gallbladder.
Go ahead with Dr. Shah. Dr. Sai question.
Right. Okay. So now, how will you manage this patient, Manish?
I would like to admit the patient for workup and optimization. After admission, we would initially send all the routine investigations for the patient, including markers, CA99.
Okay.
I would like to send CA99, and I would like to plan the patient for a CT scan of the thorax, abdomen, and pelvis in pancreatic protocol, and I would like to add medications in which I would like to optimize her coagulopathy by adding vitamin K. I would nutritionally I would
Have
get a
you
diet.
done the ultrasound of this patient or not? Did you
Initially,
get
I should get an ultrasound to rule out any.
That is the must.
Yes.
Immediately, that will be probably the first thing you are going to do.
First thing should be an ultrasound.
Yeah.
Yes.
Okay.
Okay, nutrition. Then
for nutrition, I would look into the nutrition of the patient. If the patient labs or symptomatically she seems to be having any signs of
Okay, Manish, one question. How will you find out the nutrition of the patient anthropometrically and biochemically?
we usually use a malnutrition universal screening tool in which we can use BMI of the patient, any major event in which the patient might be have NPO for more than 5 days or is acute illness is present.
Look, hang on. Don't drag in must here.
I would like to check for macronutrients and micronutrients. In the macronutrients,
Anthropometrically, how do you first tell me anthropometrically?
I would check for the height and weight of the patient, and
So
then
that is BMI then. What else?
mid-arm circumference.
Okay, right. Okay, next.
Then I will look for the skin thickness in the
Forget. Biochemically.
biochemically. I would look into the serum albumin values of the patient and serum total protein, which will be a part of the LFT panel.
Okay, what else?
I will also look into the PT-INR of the patient, and that will give me an idea about the.
Well, the PT-INR is not for nutrition as such. Look, hemoglobin. Hemoglobin is a very good.
Hemoglobin also. That
You've
would
got the
tell me about the iron
AG
deficiency.
ratio. You've got the AG ratio. You've got the pre-albumins, right? Okay. So you've got done with the nutrition. You've done with the coagulopathy. What else?
I would also to relieve the patient of any of the pruritus.
How do you
I
do
would
that?
like to add some cholestyramine or any antihistaminics.
Manish,
Anything else?
I have to ask a question here. What damage can cholestyramine do in a patient of OJ?
I'm not aware of that.
Okay, what happens to the intestines in such patients? Patient presenting with obstructive jaundice, what happens to his intestinal, the pathology in the intestines? What changes happen in the intestines?
If bilirubin is high, we can have exfoliation of the.
I know it is not reaching the intestines, no?
Yes, yes, ma'am.
Yeah.
There can be exfoliation of the mucosal lining.
Because of, not because bilirubin is high or low. What does it cause to cause that exfoliation or whatever pathology to the barrier of the intestines? What is it caused by? Are there any inflammatory markers which are raised in obstructive jaundice?
Markers like prostaglandins are usually increased.
Okay,
and,
what else? More specific.
AGF.
Have you heard of CD4s, CD8s? CD4, CD8?
Yes.
These are pro-inflammatory.
Yes. Yes.
Okay, so it causes those to increase, and that causes the breakage in the intestinal barrier. Okay, so that's one aspect. What else happens? Because the whole thing is kind of the entire microbiome is altered. What other
There
things
can
do
be,
you see?
There can be loss of villi.
Yeah, no. Other than that, what happens to the vitamins? Absorption of vitamins.
ADEK are not which are fat soluble vitamins. They
So
are
what
not.
does cholestyramine do?
They bind with bile salts and help in their excreting them.
Yeah, so in these patients, it can aggravate the deficiencies. Already existing deficiencies, if they are subclinical, it can get aggravated to a clinical level. So it should be given with a little bit of caution.
Caution.
Yeah. And you
Yes.
also mentioned CA919. Is that a is that like a true marker? Is it like an established marker of malignancy in OJs?
It gives us a idea by its value. If it is more than 100,
No,
usually
if
it
it's
is,
more than 100, nothing happens.
and if it is more than 1,000, it's usually suggestive of some. It can be malignant. It can.
No, no. It can be very high even in certain benign obstructive jaundices. So how do you figure out if it's actually raised because of malignancy or because of something else?
Because if patient is not in cholangitis, I will be checking for CA99 at that point of time.
No, but so you have a CA99 of say 500. Would you consider that as malignancy? So to cut the whole story short, it's only when it starts reducing after intervention.
Okay. Yeah.
Okay. It is seen to be very high in a large percentage of benign diseases as well. Okay. And then it falls back to normal. Absolute. So if it continues to not reduce in spite of biliary drainage, then you can kind of, say that it's probably, and if it's very high, then you can say it's more likely to be a malignancy.
Yes.
Yes.
Okay. So you've done with the coagulopathy, you've done with the nutrition. What else?
If the patient, I would also advise hydration of the patient, because such patients can.
Why would you like, and how would you do it?
If the patient is orally tolerating, I would advise oral intake of liquids, but IV supplementation might also be required with the patient having a low appetite.
No, hang on. She's already taking oral, no?
She's
already.
orally
So
tolerating.
is she well hydrated? How much hydration? How much hydration do you want?
I want to maintain a good urine output of the patient.
How much? What is good urine output? 500 ml per day?
0.5 to at least above 0.5 ml per kg per day.
At least 0.5. Is that
0.5.
adequate in a patient of? That's normal. Why do you want to? That's just barely normal. How much do you want?
0.5 to 1. I would like to keep it at 1.
No, it should be more than 1. That's a well-hydrated patient. Why did you want this hydration?
Because the patient can usually, patients of obstructive jaundice usually go into renal AKI because of various mechanisms. One is that there can be a splanchnic vasodilatation that leads to activation of RAS system, and there can also be cardioendotoxins that are not being excreted because of the.
Yes, more common ones here. Manish, cardiotoxins. Give me the common ones. Why? What happens because of bilirubin, and what's the reaction of bilirubin on the kidney?
Bile salts go and deposit in the kidney and cause nephrotoxicity.
Okay, more common.
There is again splanchnic vasodilatation because of the.
You said that. Anything else?
Kupffer cells are not functioning, so that is endotoxin point.
What happens is that these bile salts are inflammatory. They're pro-inflammatory. They cause inflammation, right? And then they cause. Okay, so you've done with that. Anything else? Which
and
missing?
also, I might look into the patient's LFT values and the counts. I might add a antibiotic for.
You're not right. You will. Why do you want to give her an antibiotic?
Because I want to prevent cholangitis, because the patient can go into cholangitis anytime.
Right. Jaundice is a immunosuppressive condition, right?
Yes.
People prone to infection, especially cholangitis. That's disastrous. Okay, you've done that. Now what else? You've done the ultrasound. You've got the ultrasound report?
We do not have ultrasound reports here.
Okay.
I should have had.
Okay. So suppose the ultrasound, right? Said there's a lesion in the head of the pancreas.
Yes, sir.
So what will you do?
I would also ask the radiologist to comment about other things, including free fluid, IHBRD, presence of any
No.
stones.
No. Just a lesion at the head of the pancreas.
Okay. Then I would go ahead with CT scan.
What kind of CT?
CT thorax, abdomen, and pelvis in pancreatic protocols.
What is
And
pancreatic?
CT angio can also.
Come on, we can't just go on with straight. You list all the CTs to me here.
Yes,
What is pancreatic protocol?
Pancreatic protocol is when the CT scan is done around 35 to 30 to 40 seconds after the initial injection of the dye.
Do you just give dye? Do you give any contrast also? Oral contrast?
Oral contrast, mannitol is usually given around 2 liters.
Yeah, you can give mannitol or you give just plain water.
Plain water.
Right. Why do you do that?
So that the bowel wall can also be appreciated.
No, so that if you give contrast, the bowel is going to obscure the pancreas and the surrounding structures, isn't it? Yes.
Sir, one moment. Professor Abhay, sir, would you like to ask a question, sir? I could see your hand up.
Yeah,
Sir.
exactly. I think
Yes,
this candidate doesn't know what is pancreatic protocol. And can you tell me what you can actually get from pancreatic protocol?
The lesions of the pancreas.
No. Tell me how it is done. How is it done?
Initially,
you have put up on your slides pancreatic protocol. That's why I'm asking you this question, because
yes.
I do a lot of pancreatic surgery. I want to know from you, what do you know about pancreatic protocol?
Yes, sir. Usually it is an extra phase is taken during the CT scans.
No. Don't run around the bush. Tell me, when is the first section taken, second section taken, third section taken, and fourth section?
First section is usually the early CT angio, which is taken usually with the help of a trigger first. Following that,
again you are going around the bush. Tell me seconds, and which is the thing that is taken. You are an excellent candidate to pass an MS examination.
The second,
running around the bush.
30 to 40 seconds, the second slice is taken.
When does the arterial phase of a pancreatic CT take place? And there are two, early and late.
Early and late arterial phases.
You don't know it, don't talk about it in your slides.
Yes.
I don't interfere in presentations because I'm only advisor, but I'm just trying to tell you, don't try to be too smart in all these things.
Yes.
Okay, thank you.
Manish, just one question. What are the criteria on CT scan for unresectability of a tumor, and what do you understand by borderline resectable tumors?
Resectable tumor is usually seen by involvement of vessels. If there are no other sign, if the lesion is localized in the pancreas, then we look for arterial involvement and venous involvement. In the artery, we look for celiac axis and hepatic artery and SMA. These three, if they are all free, along with in the venous system, we see if the portal vein and the SMV are less than 180 degree or is involved, less than 180-degree contact without any architectural deformity, or if that is usually goes into resectability criteria. And borderline resectability is when the celiac axis and SMA are less than 180-degree contact is there.
Celiac
Abutment.
axis?
Is
it celiac axis?
Celiac arteries. Celiac artery.
There's no celiac artery. It is celiac trunk actually, right?
Celiac trunk. Celiac trunks. And if there is a short segment of
so you
hepatic
better
artery
say
involved.
that you are not veteran about that, right? Please don't beat about the behind the bushes, right?
Yes.
So, Dr. Khanna sir, will you like to give some concluding remark before we start on second case?
Manish, I just wanted to ask you that, you give the patient vitamin K. You know which vitamin K is given?
Vitamin K1.
What is the name of the vitamin K1?
I don't know, sir. I can't recall, sir.
Okay. That is phytomenedion.
Right.
Phytomenedion. Okay, that is vitamin K1. How much you give it?
10 milligrams are given for 3 days, IM.
Yeah.
IV can also be given.
So by that, the INR will come to normal or not?
It should, usually it can come to normal, sir, because it's a fat soluble.
It will never
vitamin.
come to normal, you know? It will never come to normal. It will definitely decrease, but it will never touch the normal by giving this vitamin K. What are the two most common causes of the hepatorenal shutdown in a patient with obstructive jaundice? There are
One
so
is
many causes, but what are the two most important causes?
renal shutdown, sir.
Yes, hepatorenal shutdown. That is one of the complications.
Yes, sir. One is the patient can be dehydrated. Dehydration is number one. Number two, we can have, as previously discussed, that the patient can have splanchnic vasodilation because of the circulating prostaglandins. That leads to activation of the RAS axis. That leads to further ischemia of the renal arteries, causing the renal shutdown.
Ajay, can I come in here?
Yeah, please.
Manish, tell me, you are talking absolute theory read from somewhere, but whatever it is, what is the difference between acute and chronic dehydration, especially in obstructive jaundice? I'm asking you a question where a patient of obstructive jaundice is admitted under you.
Yes, sir.
How do you assess whether it's acute dehydration or chronic dehydration? Clinically examining the patient. If you don't know, say don't know.
Yes.
You got to know.
Yes.
I'm sure Ajay and others are with me on this basis because you all don't know. The second question I want to ask you here is your provisional diagnosis is obstructive secondary periumbilical carcinoma. Have you ever seen a treatment for this in an adequately prepared patient?
Yes, sir. In our hepatobiliary.
Have you assisted this surgery?
I have assisted.
Okay. What was done?
The abdomen was initially the patient was taken into the OT and abdomen was open.
No, don't tell me. What procedure was done?
Whipple's pancreaticoduodenectomy was done.
What anastomosis were done?
Pancreaticojejunostomy was done, followed by hepaticojejunostomy.
What sutures were used in pancreaticojejunostomy?
Proline was used, sir.
What was you?
Proline 4O.
4O
Round body.
proline.
Round body. Yes.
Okay. Was pancreas supple or chronic?
It, it usually varied in different cases. The last
No,
one
no,
we
no,
did,
no. You tell me what you
supple.
assessed.
It was supple.
I want
supple.
to know whether you were part of the team.
Yes, the PJ was done with a supple pancreas.
Supple pancreas. Very nice. How many layers?
2 layers were there. We had a posterior layer, then the duct was
No, posterior layer means what? Tell me the principle of pancreaticojejunostomy in a Whipple's.
the principle is that the parenchyma and the duct should everything
Parenchyma?
should be inverted in and
No, 1 minute. You said word parenchyma.
yes, sir.
You want to correct it to mucosa?
Yes, sir, mucosa.
Thank you. How many sutures were taken?
5 sutures were taken.
Pardon?
The duct was around 8 mm. We had taken 5 sutures.
Where were they taken? And now I'm going to get into deep. I don't
Yes.
want to, but I'm just trying to. What I'm trying to tell you, Manish, that when
Yes,
you
sir.
prepare for a case,
Yes, sir.
you got to be prepared.
Yes.
The examiners have been very nice with you, and they have asked only questions which were theoretical, which you are prepared for,
Yes.
and have come in a practical examination.
Yes.
If you have assisted something and if you got something, read and come. Okay.
Yes, sir. I should.
All the best to you, Manish. Hope to meet you sometime and advise you. Thank you.
Thank you, sir.
Okay, Manish, the
Yes.
2 most important reasons for the hepatorenal shutdown. One is you have to always avoid the hypotension.
Right.
And second is you have to check for the gut barrier function. These are the 2 most important things to prevent the hepatorenal shutdown. Okay, and the final comment for this is that you can never get away without doing ultrasound in this type
Yes.
of the patient. In fact,
Yes.
ultrasound should be done right in the OPD itself.
Yes.
Okay. So you have to, and because in your slides, you have not shown the ultrasound anywhere, and you have gone to CT scan and all those things.
Yes.
Ultrasound has to be the first investigation in this patient to decide that what you are going to do further for this patient. Okay.
Yes.
So that's the only comment I want to make here. Dr. Kanagal, we can finish at this point. Yeah.
Sir, yes, sir. I think we are having one more case. Dr.
Yes.
Manish, I think you were able to answer, and then probably you require some more preparation.
Yes.
That happens to everyone. Nothing to feel bad about it. So please note down the areas where you are little weak, and then you go back to the library as early as tomorrow and bridge the areas of knowledge lack so that it covers up the things. And also one thing I would request is you have a system to answer. See, a moment your question is asked, okay, if somebody is going to ask, what are the types, what are the painful jaundice, you should have a list. What are the painless jaundice, you should have a list. So like that, you prepare hand notes. Maybe it involves reading from multiple clinical textbooks as well as theory textbooks. That helps you to face the examiners in a better way. All right.
Okay.
So do you have any doubts or questions to be clarified now?
I did take a lot of, there was a lot of take back, and I will probably have to work on the lacunae to come up with questions also.
Absolutely, no problem. So you are welcome to come back to this forum to present again. This is a sort of a little extended forum because exams do not last more than 30 minutes. Here you are tested for all the areas so that you have a comprehensive learning. That is the advantage of this forum. So nothing
Yes.
to feel bad. You try avenues to spend more efforts to bridge the knowledge deficit wherever they are pointed. All right.
Yes.
Good luck
Yes.
to you, Dr. Amit. Dr. Jaswant sir, are you with us, sir? Abhay sir, please, sir.
He has done well.
Yes, sir.
Yeah, he has read his theory, etc., etc. I always have a problem with people who have worked in the wards and will not answer. Manish, you are good in theory.
Yes.
Practically, you have worked very hard, and what is happening in the ward has to be presented. That
Yes.
is what I am requesting you to do. 36 years of experience, I can tell you, you can just course through your exams without any problem. Do well, Manish. Bye.
Thank you, sir.
Thank you. Amit sir, would you like to give your comments before move on to the next case? I think sir is not. Amit sir? Sir, you are in mute mode, sir. Sir, please unmute, sir.
Yeah, Manish, you did well, don't worry. And there were some lacunae, but work hard on that. We know that you are doing 80 days course these days. So back to back, you are having these things. But overall, I think whatever you are seeing in the wards, in the HPV unit, right? So all the questions were there, which you are day in, day out, you are seeing such patients in this unit. So just as Dr. Dalvi has also said that, see, I always tell my resident that ward is the best library and patient is your best teacher. We are mere facilitators, right?
Yes.
So I think with these comments, we can stop him and ask the next candidate to share his or her screen. Manish, you
Thank
can
you.
stop sharing your screen.
Thank you very much, sir. Thank you. Akanshka, you are with us?
Yes, sir.
Okay. Please switch on your video. Try sharing your PPT.
Yes, sir.
Shilpa ma'am, Jaswant sir, would you like to add your comments, sir? I don't see him. Right. Shilpa ma'am and other faculty kindly take over. Please introduce your chief, unit chief, head of the department and start your presentation. I think Sachin Jama sir is still held up with an emergency. Ma, you please start your presentation. He has messaged me right now. Good luck to you.
Thank you, sir. Good evening, everyone. I'm Dr. Akanksha Giri, third year PG resident. I'm presenting a case of breast lump. And my guide is Dr. Ritvik Jaikar sir, head of Department of General Surgery, and Dr. Sachin Jama sir, professor in Department of General Surgery, VMGMC, Solapur. Yes, sir. Coming to history, a 72-year-old lady, homemaker by occupation, residing in Solapur, presented to the surgery OPD with a chief complaint of lump in right breast since 2 months. My patient was apparently all right 2 months back. When she noticed a lump in her right breast, the lump was increasing in size, which was initially 4 into 4 centimeter in size, and it have gradually increased to a present size of 18 to 6 centimeter over 2 months.
Akansha, let me stop here because, like Abhay said, I think we have to hit the basics. I finished asking all questions on breast. This is Shilpa Rao.
Yes, ma'am.
The first thing you said was she was apparently all right. Oh, what was it? What this thing that you used?
Yes, ma'am. She was apparently all right 2 months back, ma'am.
So, do you think she was all right 2 months back?
She never had any problem before.
Yeah. So the word you have to use is she was asymptomatic.
She was asymptomatic, yes, ma'am. Okay.
She was not all right. She was asymptomatic. Okay.
Yes,
That's point number 1. And point number 2 is I think it's general consensus for a breast lump, especially an elderly lady, to tell us about the largest diameter. We don't talk about 4x4, 8 into 5. We don't do that anymore. So
yes.
you can say that the lump was about 4 centimeters in diameter, in its largest diameter.
Yeah, yes, ma'am.
Yeah. Continue.
Coming to negative history, there is no history of trauma to the breast, no history of fever, pain associated with lump, no history of ocipil intake, no history of hormone.
No, but where is your, have you finished your basic history for you to go into negative history?
Ma'am, history of presenting illness is over, ma'am. I'm coming to negative history, ma'am.
So what happens to all the other things that happen with the presenting complaint? What about the skin? What about the breast? What about the whole the area of examination? What about other symptoms? and then you go on to negative history, na?
Ma'am,
So it's
I
always
think,
presenting complaints of complications. Then you go into negative, whatever non-complications. Then you go into the rest of it.
yes, ma'am. Ma'am,
Look, you have to find out whether this lump is benign or malignant
yes, sir.
by history and examination. So for positive history, you have to look for positive findings of history, points in history for malignancy, which are, what are the positive points in history for malignancy of breast lump?
Yes, sir. Gradual increase in the size of breast lump.
A progressively increasing.
Progressive increase in the size of lump.
Then?
Deviation of nipple.
No,
Retraction,
that
Akansha,
is examination. We're
take a
talking
deep
history.
breath. Take a deep breath.
Yes, ma'am.
Just a comment. See, when you say negative history in a 72-year-old lady, where I think most examiners are already thinking of a diagnosis,
Yes,
when
ma'am.
you start saying negative history as your first slide after you're presenting complaint, it's not a good thing to take forward. You are trying to take us to a diagnosis. You have to give us all the positives that will lead to your diagnosis. You understand?
Yes, ma'am.
Yeah. So other than the lump in the breast,
Yes.
what else will you ask for? You go progressively. What can happen
Look,
to the lump?
You've got age. You've got age.
Yes, sir.
You've got a lump in the breast,
Yes,
which
sir.
has been increasing.
Yes, sir.
What else do you look for in carcinoma of breast?
Yes, sir. I look for site
In
and
history.
size of
History.
nipple
History. What will the patient tell you?
any complaint regarding axillary swelling?
No, Rani. Talk about the lump first. What can happen to a lump? How
Whether
can
the
it
lump is
progress?
associated with ulceration of the skin or
Right.
Ulceration is an end product. What can happen between the lump and the ulceration?
So Akanksha, was there
whether
any
the lump
pain?
is painful or painless?
Yes.
Fever and changes, right.
Whether
Skin
the lump
fever?
is associated with nipple discharge or not?
Very good. Right.
Which kind of nipple discharge and what type of nipple discharge?
Yes, ma'am. There are when it
No,
comes to
let's talk
malignancy.
about your case, specifically in this case. What
In
kind
case
are you looking
of
at?
breast carcinoma, bloody nipple discharge is more common, and
What is the typical adjective you add to it?
it
Is
is
it on expression?
yes, ma'am. It is present on expression. It is not
No,
freely.
no, no. On the contrary, it's spontaneous, single duct bloody discharge, right? Serosang discharge. Okay?
Yes, ma'am.
Yeah. What else can happen?
Uh,
What can happen to that lump between the lump and the ulceration?
Ma'am, lump is not. It is not painful, ma'am. It is
Yeah,
not.
agreed. What else can happen? What can the patient come with? I mean, she'll come with a lump or she'll come with ulceration. There's nothing in between.
Ma'am, she directly came with a lump only, ma'am. And
I'm asking you, what are the stories that can happen? After the lump, can there be fixed? Can the skin get fixed?
yes, ma'am.
Can the skin get edematous?
Yes, ma'am. The stage of the carcinoma will increase.
So you have to say all those things that there is no. She says there are no changes on the skin. She says there is no swelling of the breast. Then you go to the nipple. Then you go to the axilla. Then you move on to other parts of the body, right?
Yes, ma'am.
Hmm.
Should I continue with the negative history?
Please.
No, why are you obsessed with the negative history? You haven't finished your history yet.
Yes, ma'am. My patient presented with a breast lump of largest diameter 8 centimeter in size, with no history of any ulceration or with no history of any ulceration over the lump, with no history of any trauma, fever, pain.
No, see, trauma, fever is etiology.
Yes, ma'am.
We are not talking about etiology right now. We are talking about the lump itself. So you have to tell me everything about the lump.
Yes, ma'am. The lump was irregular. The lump has
No. On history, Rani. You finished saying the lump cut this thing, then you went and spoke about the nipple. And what happens to the nipple?
Nipple is deviated to the
It is
right.
not deviated. It is pulled. There's a
Retracted and
difference.
yes, ma'am.
Deviation is pushing. It is pulled towards, and is it symmetrically pulled?
No, ma'am. It is not symmetrical.
Anyway, it's difficult for the patient to tell you this on history. What else can happen? After you finish the breast and you finish the nipple areola complex, which is the next area you will ask her about?
Axillary region, ma'am.
What will you ask her?
I'll ask about any swelling in the axilla. To rule out axillary lymphadenopathy.
Okay. After axilla, what will you ask her?
Complaint of similar complaint in the other breast or in the
You
axilla.
will finish with the arm. You will ask her
Yes,
if there's
ma'am.
any changes in her arm.
Yes, ma'am. Whether is a complaint of lymphedema or also the swelling in
Just
supraclavicular or infraclavicular region.
see, now you're getting there. Yeah, so you'll finish all this and then you'll go on to the opposite breast.
Yes, ma'am.
Right? And then you will ask for
Negative history.
Metastasis.
You will ask
Next.
for history of spread of the disease. There is no such thing as negative history. Every history is positive. Either it is a pointer or it excludes, but there is no such concept as negative history.
Okay, ma'am.
Yeah. So
yes,
just stop. Don't repeat that word again.
Yes.
Okay. Now you finish this. Where next are you going to ask for? What other histories are you going to ask her? Pertaining to the lump. Local ho gaya. After local, what will you ask?
After local systemic.
So what all will you ask her?
Is there any abdominal complaint or complaints in the same arm or contralateral arm and back pain, other complaints like back pain or headache, nausea, vomiting? Yes, ma'am.
So you will ask all those things.
Yes, ma'am.
Right? After you finish asking all that, then you will move on to your history of etiology.
Yes, ma'am.
And what is that?
Yes, ma'am. My patient have no history of trauma to the breast, no history of fever, pain associated with the lump, no history of headache, nausea, vomiting, or blurring of vision and seizure.
You already finished that. You already finished telling me all that.
Forward, okay.
Now we are going to etiology. Tell me the etiologies that you will ask for.
Yes, ma'am. There is no history of radiation therapy exposure. There is no history of hormonal replacement therapy exposure. No history of occipital intake. There is no history of similar complaint in complaint in the past or in the family. There is no history of past operative history. There is no past history of breast surgery. Then, ma'am, she coming to. Should I continue, ma'am?
No, in a breast.
Yes,
if you're telling me about HRT and you're telling me about OC pills, then you have to start with menarche, menopause, parity, abortions, the whole gamut.
Yes, ma'am. My patient had menarche at the age of 14 years and menopause at the age of 42 years. She had a history of normal regular menstrual cycles and she was married at the age of 18 years, but she was nulliparous, ma'am. She never conceived.
Okay.
Yes, ma'am. Also, there is no history of similar complaint in the family and no history of other malignancy related to the BRCA gene mutations and another P53 and Cowden syndromes.
So in all this history you've provided us, what are the likely factors which up her risk for cancer?
Yes, ma'am. Nulliparity is a major risk factor.
What else?
And, also, she never breastfed.
If she's not pregnant, she's unlikely to breastfeed.
Yes, ma'am. Nulliparity is a major factor. Being a female female sex, and 72 years of age. These are the three main risk factors for breast carcinoma.
Yeah, she's had an early menopause, right? Relatively
yes,
early menopause.
Relatively early menopause, ma'am. 3 years as compared to the conventional.
So all these will add up to your.
Yes, ma'am.
And she's obviously post-menopausal, right?
Yes, ma'am.
So what else will you ask her?
Mm.
Would you ask her for history of weight gain in
Yes,
the
ma'am.
last
In the
decade or
postmenopausal women, history of weight gain is more common as compared to the history of weight loss and loss of appetite.
yeah, so you will ask her all these
Yes, ma'am.
questions
Yes,
in
ma'am.
this order. Okay?
Yes, ma'am.
Akanksha, you mentioned about no history of breast surgery in the past. So
Yes.
what is the importance of asking this history?
Yes, sir. Any history of breast surgery suggestive of atypical ductal hyperplasia or atypical lobular hyperplasia or lobular carcinoma in situ is significant. Even a surgery for ductal papilloma is significant, which is the most common benign condition which leads to breast malignancy.
So
Yes.
can you tell us
Does
what is the
duct
incidence
papilloma
of
happen at
developing
this age?
malignancy?
No, ma'am. Duct papilloma happens at
I'm
early
sorry,
age.
I'm interrupting you, but you have finished answering his question.
Yes, sir. Sorry, sir.
What is the incidence of malignancy in these various benign conditions as you have just mentioned?
Yes, ma'am. Yes, sir. Relative risk of getting breast carcinoma in this condition is 3.7 to 4.2, sir. When it comes to atypical ductal hyperplasia, these are the proliferative disorders without atypia. They have a relative risk of 3.7 to 4.2. Yes, sir. As compared to normal population.
Okay, go ahead. Madam was asking some question.
Yes, ma'am.
I was just asking how common is papilloma at 72?
No, ma'am. It is not. It is not at
And
all.
papilloma
Ma'am, I just
correlating to an IDC is rare.
very rare.
Papilloma itself can happen by itself and undergo a malignant this thing, but IDC and papilloma, not really. Okay?
Yes, ma'am.
But sclerosing adenosis, there's so many other things that even fibroadenomas, multiple, it's now showing that even those can change, like especially the florid ones and the, you know,
Yes,
the
ma'am.
not,
Very hyperplasia.
yeah, so all those can also cause. So you have to mention all of those, right?
Yes, ma'am.
Okay, I think we should come to exam if we have to finish you by 10. Tell us.
Coming to past and personal history, ma'am. She
Come
had.
to the examination, we've
Okay, ma'am.
finished all of it.
Yes, ma'am. I examined.
Please don't put that picture on for too long, otherwise Dr. Kanagal, it'll get blocked. Chalo, bolo.
Yes, ma'am. Patient was examined in well-illuminated room with proper exposure and after informed consent. Patient was conscious and oriented to time, place, and person. Her pulse rate was 72 beats per minute in right radial artery with regular rhythm and volume. Her blood pressure is.
Let's go into the local exam.
Okay, ma'am. Coming to inspection, on examination in sitting position with arms by the side, there is a swelling in right upper outer quadrant of right breast with nipple deviated slightly lower and outer. On bending forward, both the breast fell forward. On raising arms above the head, right nipple is seen at lower level than the rest with no swelling, with no visible swelling in the axilla. Skin over the swelling shows hyperpigmentation and edema. There is no evidence of nodules or ulceration. Distortion of the right nipple areolar complex is present. Left breast and left nipple areolar complex appears normal. On palpation, all the inspectory findings were confirmed on palpation.
Akansha, wait.
Yes.
You should also mention whether there are dilated veins in that area. Maybe not at 72, but it's, I mean, if you have to complete the thing, then we also say that there are no dilated veins seen. It's a little younger lady, then I would have a differential in mind, right?
Yes, ma'am. No, she'll be fine. Yes, ma'am.
Yeah, go on.
Coming to palpation, all inspectory findings were confirmed on palpation. No local rise of temperature or tenderness. Left breast was normal. There was a single lump of size 8 into of larger size 8 into 6 centimeter in upper outer quadrant of right breast, extending into lower outer quadrant, globular in shape, ill-defined in margins, irregular surface, and hard in consistency, with no nipple discharge. Fixity to the breast tissue is present, and fixity to the chest wall is absent. Overlying skin was non-pinchable, and there is no evidence of lymphadenopathy in the axilla or neck on either sides.
Again here, please take the mid-arm circumference on both sides.
Yes, ma'am.
Okay, for documentation,
Yes, ma'am.
right?
Yes, ma'am.
Anything else in the other systems?
Ma'am, other system examination appears normal.
Okay.
Yes, ma'am.
Now let's come to the approach. How will you approach this lady?
Ma'am, I'll investigate her further.
Give me a clinical diagnosis first, a working diagnosis, and then you go on.
Yes, ma'am. Sorry.
That's okay. We don't need your screen. Say.
Ma'am, coming to diagnosis, this is a case of 72-year-old nulliparous female with lump in right breast, probably malignant, with no clinical axillary lymphadenopathy, with no clinical evidence of distant metastasis. Clinical stage T4B, N0M0, stage 3B.
Okay.
Yes, ma'am.
Proceed.
Coming to investigations, to support the diagnosis, I will do sonomammography of the patient, and to confirm the diagnosis, I'll do true gut biopsy. And to do metastatic workup, I'll do X-ray chest, USG abdomen and pelvis, CCT thorax, abdomen and pelvis, and LFT and ALP levels now.
So, the whole thing, you can start with saying, I'd like to do the triple assessment, which is a standard format, right?
I like to do triple assessment. I'll do physical
Then you
examination
go
of the
all
patient.
yeah. And this is a pretty large lump. So if you're going to do CT scan also, you're going to do LFT also, you're going to do an X-ray chest also. I mean, why should you be doing all these things? What is the standard protocol?
Ma'am,
What does this come under clinically? What does it come under? What kind of breast cancer is it?
locally advanced breast carcinoma, ma'am.
It's a locally advanced breast cancer. So what is the investigative protocol for locally advanced breast cancer?
I'll take true cut biopsy of the lump.
Okay. How many cores will you take? And what needle will you use?
Yes, ma'am. For true cut biopsy, I'll use a needle of 8 to 16 gauze.
8 to 16 nahi hota, bacha. In an MS exam, you have to tell me what you will do.
Okay, ma'am. 14 to 16 gauze.
I will use a 14 gauge needle.
Yes, ma'am. 14 gauze needle.
You don't give me, this is the lady, this is what I'm going to do, right?
Yes, ma'am. I'll take
Okay.
14 gauze needle.
And how many cores will you take?
I'll take 4 to 6.
I'll take 6 cores. Say, be specific. I'll take 6 cores, right?
Yes, ma'am.
Okay. What else will you do? Before you did this, you do a, before the core, you'll do a?
Sonomammography of the breast.
What do you mean by sonomammography?
Ma'am, at this time, this mammography will be diagnostic. The mammography assisted with the ultrasonography of the breast.
Why do you want to do both?
Ma'am, mammography will tell me whether the lesion is multifocal or multicentric, whether the calcifications are present or not.
Ultrasound will not tell you whether it's multicentric.
Ultrasound will tell whether what kind of lesion, whether it is solid, cystic. It will differentiate. Both will help to differentiate benign lesion from malignant lesion, ma'am.
In a 72-year-old, see again, like the previous, you're going very theoretical.
Okay.
Yes, in a younger individual who has denser breasts, yes, we would like to do both for the breast itself. In a lady who's 72, a mammography is the gold standard.
Yes, ma'am.
And sonography is done for other parts of the breast. You want to look at the
axilla also supraclavicular region also.
Yeah. So you are not really going to this thing that all of this, whether it's multifocal, multicentric, whatever else, you will see on a mammo. The lady won't have dense breasts at that age, right?
Yes, ma'am.
Yeah. So it's in a younger age group, yes. But here mammography is the gold standard.
Yes, ma'am.
Right? And a sonography for the rest of the area. And then what is the investigation you would do for a metastatic workup?
Ma'am, X-ray chest will rule out ribs and sternum and
what is the standardized protocol for
ma'am,
staging workup?
CCT thorax and abdomen pelvis will first, and also to rule out metastasis, gold standard is PET CT.
No, so it's
More
either
commonly
or.
CCT thorax.
Yeah, so it's an HRCT of the chest.
HRCT.
So CCT of the abdomen and a bone scan. So you do these three things as one thing, or now the NCCN guidelines say that a PET can be used as an alternative to doing multiple tests, right?
Yes,
So
ma'am.
it's either this or that. You don't do everything.
Yes, ma'am.
Yeah.
Okay, ma'am.
Okay. So what will you see on the core biopsy? I think I'm going to stop asking questions. It's like a 1:1. Please take over, somebody.
No, Akanksha, go ahead.
Yes, sir. Sorry, sir.
So tell us just what are the findings on mammography which will raise a suspicion about malignant breast lump?
Yes, sir. A radiodense lesion with speculated margins having microcalcifications, multicentric multifocal lesions will raise the will be suspicious for malignant lesion.
Any other finding on mammography in malignancies? What happens to the architecture of the breast?
Yes, distorted architecture is one of the significant finding in case of malignant lesion.
What do you understand by microcalcification?
Yes, sir. Microcalcifications, there are different types of microcalcifications, like pleomorphic, linear. They are
So,
present because of the necrosis, sir. These are the dystrophic type of calcifications, and
so
they are present
what is the size of the
less
microcalcification?
than
When
0.5 mm in size, sir. On imaging, less than 0.5 mm in size.
Dr. Akansha,
Yes, sir.
why would you like to do a mammography in this patient with such a large lump?
So just to rule out whether she has multifocal or multicentric.
No. You can do that by ultrasound. Why a mammogram? Because you want to pick up impalpable lumps in the other breast.
Yes, sir. Yes, sir. To look for.
That is why.
Yes, sir.
Not because you want to confirm whether this breast is having malignancy or not. That you've got a core biopsy.
Yes, sir.
Right. Ma'am, please.
Okay. So you also want to rule out DCIS, right? So you'll be able to see so the mammography is not for the diagnosis, like he said.
Yes.
Yeah. So after you've done all this, now this is a locally advanced breast cancer. What does your core tell you?
What does, ma'am? Sorry, ma'am.
What does the core biopsy tell you?
Core biopsy is suggestive of infiltrating ductal carcinoma. Yes, ma'am. Infiltrating ductal carcinoma only.
That's not all you get on a core, na? Then I'll do an FNAC.
Ma'am, receptor status is not known, ma'am. Like, only the diagnosis of final diagnosis of infiltrating ductal carcinoma is given. Her ERPR and HER2 receptor status is not done
What
yet.
is NOS? Dr. Kansha, what is NOS?
What is, sir? Sorry, sir.
They say infiltrating ductal carcinoma, NOS.
Yes, sir. Infiltrating ductal carcinoma not otherwise specified or no special type. It is the most common type of breast carcinoma when it under infiltrating ductal carcinoma types.
Okay. Yeah. So what else can you see? So you want to know the IHC or you don't want to know?
I want to know the IHC to.
Okay, so let me tell you, this
match.
is ER/PR positive, HER2 negative. That's her. What else are you going to look at the core?
I'll also look for the Ki67 activity of the
Okay.
tumor and yes, ma'am. Receptor status and Ki67 activity.
Don't you want to know the grade of the tumor?
And grade of the tumor
They
according
have a classification that they give you, no, at the end of
Yes,
the
ma'am.
core. Do you know what the classification is?
Yes, ma'am. Bloom-Richardson
Yeah.
grading
So
classification.
you have to tell us all the criteria that fit into that mitosis, the grading.
Mitosis tubule formation and nuclear
Yes.
pleomorphism.
So all of that has to be mentioned.
Akanksha, what is Ki67?
Ki67 denotes multiplication level of multiplication of the tumor cells. If the Ki67 activity is more, like the tumor cells are multiplicating at higher rate, at faster rate, and if Ki-67 activity is less, their multiplication rate is lower.
So actually the full name is not Ki-67, although we speak like that only, but the exact name is Ki-67-Li. Li stands for labeling index, right?
Yes, sir.
Why it is called as Ki-67? Why not Ki-65 or Ki-66, or why not Ki-70?
I'm not sure, sir. I'll read about it.
Okay. So it's a marker of proliferation.
The marker of proliferation, yes, sir.
Okay.
Okay, so she is ER/PR positive, HER2 negative, grade 3,
Yes.
a score of about 7.
Okay, ma'am.
Okay, how will you manage her?
Ma'am, as this is the case of locally advanced breast carcinoma, I would like to give neoadjuvant chemotherapy first to decrease the size of tumor, and then I will take operative decision, and I will
So what?
start
No, wait. So what chemos do you give?
under neoadjuvant chemotherapy, ma'am.
Yeah.
I would like to give 4 cycles of adriamycin, 4 cycles of AC followed by 4 cycles of taxanes.
4 cycles of taxanes. Which taxane do you give 4 cycles of?
Ma'am, paclitaxel and docetaxel, they are the more commonly used chemotherapy agents.
So
No?
Pacli also you give 4 and Dosi also you give 4.
Paclitaxel is given 3 weekly, and paclitaxel
No.
is given weekly, and docetaxel is given 3 weekly.
So how many doses of Pacli do you need to give?
Total 12 cycles of
Taxanes. If you're giving Pacli, if you're giving Dosi, and what is the problem with giving these things? Do you want to do a workup before you start her on these things?
yes, ma'am. With taxanes, most common side effect is neuropathy, and so and with Idiomycin, more common side effect is cardiotoxicity. So I
Yeah.
would like to rule out presence of these high risk factors in the patient. Like
You don't want to rule out. You will tell me what you do. What is the test that you perform? Why is everything of like a negative history? I will rule out. You will tell me this is what I will do. Which test tells you about cardiac function?
2D echo test.
Yes, so you'll do a ECG and 2D echo before
ECG
giving
and 2D
every cycle of
chemotherapy.
adriamycin,
Right.
right? And what will you do if the patient develops neuropathy?
Second line chemotherapy regimen should be used.
No, it's temporary. What would you give her that will alleviate her pain? You have to counsel her and give her something to alleviate the pain. You can't stop the
Neuropathy,
vaccines for her.
gabapentin is more commonly used to.
No, it doesn't work. It doesn't work.
I'm not sure.
Okay, so read that up also.
Yes, ma'am.
Yeah. Okay. So you've completed the whole thing. And what are you looking for when you start neoadjuvant?
Size of the tumor.
What are you trying to achieve?
Response of the tumor after each chemotherapy cycle.
So you want to look for PCR,
yes, ma'am.
right?
Complete response, yes, ma'am.
Right? Okay. So what is a complete response?
Ma'am, complete response is when disappearance of all the lesion and lymph nodes. Complete
On microscopy post-operatively, right? So what you're trying to do with the NACT is look at the PCR. You're trying to achieve PCR.
Yes, ma'am.
Akansha,
Right?
are you aware of what is RECIST criteria?
Yes, sir. RECIST criteria 1.1. It is a criteria to evaluate response of chemotherapy in solid tumors. It has four main things. First is complete response, disappearance of all the lesions and lymph node on imaging and clinical examination is complete response. Partial response includes more than or equal to 30% decrease in the sum of longest diameter of the lesion. Partial stable disease includes disease is not no partial response also, and no progressive disease also. And under progressive disease, more than or equal to 20% increase in the smallest diameter of the lesion.
So once you have measured the tumor in the first OPD, visit, and then you subject your patient for neoadjuvant chemotherapy.
Yes, sir.
Subsequently, after each cycle, during follow-up, you will like to measure the size of the lump and
Yes.
assess the breast,
Yes.
right?
Yes, sir.
So how will you do that? And you
Sir,
will make a note of that. You will, somewhere you will record it, right? So
yes, sir.
at your college, I think you must be doing that. So how you do that?
So size of the lump by examination also, and by imaging modalities also. MRI,
No,
CT,
but
or
how you
PET.
measure? How you measure the lump? By a scale?
Yes, sir. The caliper scale is used to measure the size of the lump.
So you are measuring it by vernier calipers.
Vernier calipers, yes, sir.
You are doing it by that? Are you using vernier calipers?
We are not using.
Okay. So
So,
how
no,
can
this
you
is one of
actually
my pet
assess?
questions. I have to ask this. Why should you be using the verniers?
Ma'am, the exact size of the lump to
So
get
how do you calculate?
the longest axis of the lesion is used.
No, that's not how you calculate.
No, I'm not sure about it, ma'am.
You need to find the longest axis, you need to find the radius, and you need to find the volume, right? Based on that. And why verniers is better than measuring with a tape?
Because the vernier is more conventional, ma'am.
No, it's not conventional, unfortunately. It gives you depth.
Standard.
Whereas when you measure with a tape, you always upsize the tumor. Okay, like you go back and examine with the verniers and examine with a tape. You will find with a tape, it'll be 8 centimeters, whereas on a vernier, it will be 6 centimeters. So the
The
stage
tape,
of the tumor also changes.
right? The tape gives you the circumference, goes around, right?
Yes, sir.
We just need the length of the diameter.
Yeah.
Yes.
So go back and measure the next time, measure it with the verniers and see the difference. Okay?
Yes, ma'am.
Hmm.
Yes, ma'am. After giving neoadjuvant chemotherapy, I would like to manage the tumor. I would like to assess whether the tumor can be excised by.
The tumor is now 2 centimeters.
Yes, ma'am.
Skin is normal, axilla is normal.
Yes.
Clinically.
I will plan breast conservation surgery in this case if the tumor size is less than 2 centimeter, ma'am.
Akanksha, what do you understand by breast conservation surgery, and what are the absolute contraindications and what are the relative contraindications of BCS?
Yes, sir. Under absolute contraindication, there's only one single term, sir. Pregnancy is the absolute contraindication, and when it comes to relative contraindication, contraindications regarding breast lump, regarding lump, size of the tumor and size of the rest of the breast tissue is important. Also, whether we can achieve negative margins or not is important. Then multicentric tumors, multicentric and multifocal tumors, we cannot go for breast conservation surgery. Also, tumor in central quadrant, and contraindications related to the systemic diseases like SLE, scleroderma, also previously irradiated chest. These are the relative contraindications for breast conservation surgery, sir.
Okay, suppose your patient is a BRCA1, BRCA2 positive. So in that patient, will you like to offer BCS?
No, sir.
So that is absolute
Yes, sir.
contraindication.
Yes, sir.
then,
Absolute. Yes, sir.
right?
Yes, sir.
Okay.
And
You have
pregnancy
read
is really
something
not
about.
a contraindication anymore. It depends on the trimester of pregnancy that the patient comes to you with. So if
Yes.
it's in the last trimester, you can still offer because it's a young patient.
Yes, ma'am.
And if you've ruled out a genetic prediction, you could offer the patient breast conservation even there. So it's not really an absolute contraindication today. Yeah.
So,
Yes, ma'am.
tell me the difference between the multicentric and multifocal tumor.
Yes, sir. When the distance between the two lesion is more than 5 centimeter, it is called as multicentric lesion. And when they are present in the same quadrant, and when the distance between the two lesion is less than 5 centimeter, it is called as multifocal lesion.
Is it the criteria really? The distance should be 5 centimeter or more than 5 centimeter?
Whether the lesion is present in different quadrant of breast, or whether they are present in the same quadrant of breast. If present in different quadrants, it is multifocal. If present in same quadrant, it is otherwise. Present in different quadrant, it is called as multicentric. And when present in same quadrant, multiple lesions, it's called as multifocal.
Okay, so which of out of these two, which carries a better prognosis? Multicentric tumor or a multifocal
No,
tumor?
sir. Multifocal tumor carries a better prognosis because I can excise the involved quadrant.
Okay, go ahead.
Okay.
So what is your plan for this patient?
Yes, sir. I'll decide whether the MRM or breast conservation surgery after the response to the neo chemoadjuvant neo.
You already said breast conservation, right? So now I think somebody asked you what breast conservation involves. What all do you do?
Under breast conservation, ma'am, I will do wide local excision of the lump, and with I will excise the lump, and I'll also do axillary clearance of the. After sentinel lymph node biopsy, I will do axillary clearance of the involved axillary lymph nodes.
Vikasha, what do you understand by wide local excision in the breast lump? What do you understand by that? Wide local excision.
Excision of a no sir, by I use that term by mistake. Lumpectomy with 1 centimeter of margin is done in breast conservation under breast conservation surgery, and axillary nodal clearance system.
No,
And what else?
Not a part of the breast conservation surgery. You know? It
And,
may, it may not be. You know? It is not always a part of that.
Yes, sir.
You
And
have to address the axilla separately.
Yes, sir. By separate incision, I'll address the axilla. Yes, sir. I'll place a clip at the center of the. I'll place a clip.
No, your breast conservation is not complete yet. What does the breast conservation technique mean essentially? You said lumpectomy,
yes,
axillary approach, and
radiation therapy after.
Say all three together.
Yes, ma'am.
Right?
Yes, ma'am.
You know, when you are removing the breast lump, do you mark those that lump for histopathology?
Yes, sir. Mainly 3 markings are used. Superior margin is marked with a short thread, lateral margin is marked with a long thread, and the base of the lump is marked with a double suture. So SSLL and double D.
Okay. Then what else you do when you have done the wide local excision there with the 1 centimeter margin?
Yes, sir.
What other things are done at the time of the surgery?
Sir, breast reconstruction can be done, but not in case of breast conservation surgery.
Are you going to put the clips there?
Yes, sir. I'll put a clip at the site of lumpectomy so that after the chemotherapy, the site of main site of tumor is marked.
To put the multiple clips, you know?
Yes, sir.
All the margin
Either
and
the
also.
radiopaque clips or the magnetic slits.
Okay, so after you've done your surgery and it's all come good, now what are you going to do? You finished all the chemo, you finished the surgical aspect.
Yes, ma'am.
Now what?
Then according to receptor status, I will start the patient
He
on.
is ER/PR positive, HER2 negative.
Yes, ma'am. I'll start as this patient is in postmenopausal phase. I will start third generation aromatase inhibitors. Mainly either the letrozole, anastrozole, or exemestane, given for a period of 5 years.
You can't say or you. If a patient comes to you now, are you going to say I'll give you this or that or that? I would like to start one. Which is the one you would? Exemestane is not a primary starting point.
Yes, ma'am.
What would you like to start?
Letrozole.
Yeah, better than it's cheaper than anastrozole is the thing. So yes, you would start letrozole. Anything else you would like to give with that?
And tamoxifen is also given, ma'am. But
Would you give tamoxifen to a 72-year-old lady? Have you heard of bisphosphonates?
yes, ma'am. To prevent osteopenia, along with letrozole, I will give bisphosphonates plus vitamin D and calcium supplements.
Which bisphosphonate would you give? Oral, IV?
Oral bisphosphonates, ma'am.
Okay, we like to give a loading dose of zoledronic acid, like when the patient comes, this thing, and then later on you can put her on oral, right? And when would you ask her to follow up after the radiation? First follow up?
I'm not sure.
How long do you give the lady letrozole?
Letrozole is given for a period of 5 years, but it can be extended up to the year of, for a period of 10 years.
No, letrozole cannot be extended for 10 years. Tamoxifen can be extended. Right? What are the side effects of letrozole?
It causes complete estrogen deficiency.
What are the side effects? What are you going to look for when the patient follows up with you? Why do you want to give bisphosphonates and calcium and vitamin D?
It causes osteopenia. So
Because it's very severe osteoporosis, right?
yes, ma'am.
So
I
you
would
want
like to for any development of any pathological fractures.
So you don't wait for that. You make sure that she doesn't get one of those.
Yes, ma'am.
Yeah. Okay, I think we've taken as much time as an exam would take normally. I'm done with my questions. If anybody else has, please go ahead.
Asha, what are the various types of radiation which can be given after the breast conservation surgery?
Yes, sir. Mainly there are two types of radiation, with, either the whole breast irradiation or accelerated or partial breast irradiation.
So is it done after the operation or it is how it is done?
Accelerated partial.
It is external beam therapy or it is something else can also be done?
Sir, brachytherapy or external beam therapy can be used, sir.
Yes, how do you give the brachytherapy to these patients?
Sir, there are different type of balloon catheters are inserted at the site of tumor under image guidance, and fractions of radiations are given, sir. Yes.
At the time of the surgery, you can put all those things, tubes and all those things can be put for the brachytherapy patients. You know, why all this combination is there, giving the patient neoadjuvant and then followed by the surgery and followed by the chemo or radio? What is the basic principle for that?
It decreases the chances of loco-regional recurrence, also the systemic spread, and also recurrence of the tumor.
You know, what are the basic concepts?
It increases the survival, original survival rate of the patient is increased, sir, by using combination of therapies.
You know various concepts of Fisher concept and Holstedian concept and spectrum concept. Do you know all those things?
No, sir. I'll read about it, sir.
What the Holstedian concept is, and that is why he always used to do the radical mastectomy. You know what is called a Halsted radical mastectomy.
Yes, sir.
He thought it is only a loco-regional disease and it progressive in order. But then it was found that it is not a loco-regional disease only. It is from the very beginning, it is systemic disease. And that is the Fisher concept. Then both were not correct and both were correct. Came out to be a spectrum concept. Okay, in which it is said that breast cancer is both loco-regional as well as systemic. And that is the basic principle of combining all these things. That by giving the neoadjuvant treatment, you are taking care of the systemic as well as you are downstaging the tumor, followed by the surgery to take care of the loco-regional part, and followed by the radiation or the chemotherapy. So these are the concepts which are there. You know how much time does it take to become 1 centimeter palpable tumor of the breast? How much time does it take?
I don't know, sir.
You know what is the tumor doubling time of the breast cancer?
It is 3 to 6 months, sir. Yes, sir.
It's around 100 days, you know?
Yes,
It's
sir.
around 100 days. And it takes at least 5 years to become one cell to going to the 1 centimeter size.
Yes, sir.
And it takes around 30 doublings which are there. So one cell becomes 2, 2 to 4, 4 to 8, like that. It will take at least 30 doublings like that. But it has been seen, even if it becomes 1 centimeter tumor, it can metastasize even before that.
Yes, sir.
If it is only 22nd doubling which is there, it can metastasize. So that is why it is said that breast cancer, right from the very beginning, is a systemic disease. Okay, so that is the concept that why you are going for all these things. Okay.
Can we?
Yeah,
Can we?
Akansha, can you just name some 5 landmark trials in carcinoma breast? Just
Yes.
name them.
Yes, sir. NSABP trials are major, sir. Like NSABP B4, B6, B34, 37, and then ESOR-TC trial.
Yes. Any other trial are you aware of? Any trial which has emerged from India?
No, sir.
Okay, anyway, not an issue. You can read it about that, right? In
Yes, sir.
fact, you should be aware of that, right?
Yes, sir. I'll read about it, sir.
Yeah, Khanna sir, can we call it a day or you want to ask some more questions?
No, sir, I'm fine. I only wish the student to ask any doubts if she is having. That is all.
Yeah.
That we normally allow them because intensity of 1 hour of questioning, then they should get the benefit of clarifying their doubts.
So Akanksha, do you want to ask any question to the examiners?
No, sir. No, sir.
Okay, Dr. Sachin has joined, man. No, I didn't see him. Did he inform you about anything? No.
No, sir. He had some emergency in his hospital, sir.
Okay, right. Shilpa ma'am, can we call a close, ma'am? Rajiv
Yes,
sir.
please. Yes.
Thank you, everyone. I look forward to yet another week of clinical discussion next week. Amit sir, Khanna sir, Rajiv sir. Khanna sir, do we have anything to add, sir? Can we call a close?
Yeah, I think we can close now. Yeah.
Thank you, sir. Thank you very much.
Okay.
So,
thank you and good night all. Good night, sir.
Yes.
Good night, everyone.
Thank you, sir.
Good night, sir. Good night, everyone.